be busy, you're more than welcome to stop me at any point, ask questions. You can do it either verbally, just put on your audio and just stop me and just ask, or alternatively, you can just put it up on the chat or whatever it is. And like I said, my apologies, I was also running just a minute or two late. So sorry if you were waiting before that. Yeah, but anyway, let's get going so that we can try and learn something. So whoever was, with us last week on Monday, will probably look at today and think, okay, we're looking at the same thing, but we're actually looking at something completely different. So we're going to try and simplify what we're looking at, and hopefully you guys will get a bit of an idea of how to look at this. So one of the things that I've noticed a lot of our doctors have a problem with is once they see a tachycardia, for some reason the brain shuts down. I don't know why. Now, that's not all of you. I'm not saying everybody who sees a tachycardia, but generally, especially amongst the junior doctors, when you see a tachycardia, you get a tachycardia yourself, which is quite understandable. It's quite a dramatic thing to see on an ECG. So in this case, we have a patient who presents with one of the symptoms of a tachycardia, which is either going to be palpitations, which is probably the most common presentation. You get patients who present with dyspnea. They present with a weakness, syncope. They can even present with low blood pressure. They can present with signs of acute ischemia. They can present with signs of acute cardiac failure. So they can present with quite a few of these things. Now, in this ECG talk specifically, what I'm going to concentrate on is looking at the tachycardia to try and figure out what it is, and sort of compare it to last week's that we had. Now, what I want to do is just quickly go through the fundamentals of looking at a rhythm strip, all right, or looking at the rhythm to determine what it is. We know that this is a tachycardia. Now, if you were to look at the, on our machines now, we have the readout, but if you, like me, I'm a little bit older, so we used to work it out. So we used to actually count the number of blocks and divide that 300 divided by the number of blocks. So you're actually going at about close on to 170 beats per minute. And generally, once you go over 150 beats per minute, you're talking about a pathological tachycardia. Once you're under 150, majority of the time, you're talking about tachycardias due to fever, due to pain, due to things like that. But once you go over 170, 150, you're generally talking about pathological tachycardia. So let's have a look and see how we look at the rhythm now to be able to determine what type of a tachycardia we have. So for those who were here last week, you may remember I put this, I typed this up as well. So number one, we look for P waves, which is the atrial function. Is there an atrium that's functioning? Number two, we look for the PR interval. So in other words, we are looking at the time it takes from the atrium contracting to the ventricle contracting. That's the PR interval. Number four, we're looking at the QRS complexes themselves. Sorry, QRS complexes. So are they narrow or wide? The reason why we look at that is that a narrow complex is generally, it means the ventricle is receiving its electrical signal from the atrium. And if it's wide, it generally means that the ventricle is receiving it is not receiving anything from the atrium and is actually functioning on its own. Okay. Number four, is there a QRS complex after every P? Okay. In other words, is the ventricle contracting after the atrium, and is it happening every time? That's what we are looking at. Okay. And number five, do those groups of PQRS, all right? So in other words, the ventricle and the atrium contractions, are they regular? Okay, so these are the five things that we're going to look for. Now, let's look at our ECG that we have here. So let's pick AVL. That would probably be a good one to look at. So if we look at AVL, the first thing that we've got to look for is, do we see any P waves? You could argue that that is maybe a P wave, but to be dead honest, we don't really see any P waves per se, all right? So there's two reasons to not see P waves. Number one, they're not there. So in other words, the atrium is not functioning. Or number two, they're hidden away. In other words, something with a larger amount of electricity is masking them or camouflaging them. So that's the two reasons that we don't see P waves, right? Now, in this situation, looking at, let's say, V2, for example, where you can see there's definitely no P waves over there, we would guess that it's because of this huge amount of electricity that's passing through the ventricle that the P wave is being masked. Now, if I'm going too fast, or if you want me to repeat something, please, by all means, just stop me and say, listen, I have no idea what you're talking about. This doesn't make any sense to me, and I'll try and explain it again. If you are getting it, that's great, okay? And to those of you who maybe haven't joined us before, if this seems like it's a bit already sounding a bit complex, then on the YouTube channel, I've got about 4 lectures on the very, very, very basics of interpreting ECGs. So we go through each of these things in a very, very slow manner and in a very easy manner, but it's generally what we're talking about now, right? So in this one, we can say, okay, we don't have any P waves that we can make out per se. So it's either that the atrium is not functioning or the atrial contraction is being masked, because the atrium is much smaller than the ventricle, so it produces much less electricity. So because we don't have a P wave as such, or not a P wave that we can definitely see, we can't really talk about the PR interval. We can't say, okay, it's taking this long for the signal to get from the atrium to the ventricle. And if we look at our QRS complexes, they're quite narrow. So that means that the ventricle is getting its stimulation from the atrium, or in other words, the AV node is being stimulated by the SA node, but that is why it's being hidden over here probably. You're right. So it kind of tells us that there most likely are P waves, but they are being hidden. All right. And then we can't really say that there's a QRS after every P because we can't see P waves. But the one thing that we can say is that our QRS complexes, which we can see, are absolutely regular. So if you look at that, I mean, there's basically almost no difference between, for example, that R and R, and this R and R, and this R and R. And let me ask you, is that normal or abnormal to have absolutely no difference? I mean, if I'm counting it out here, they're almost exactly the same. 1, 2, 3, 4, 5, 6, 7. We go here, 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. And I know people get shy, so that's why I'm saying you can even put it on the chat. Do you think that's normal to have absolutely no difference from one contraction to the next? The way that you can think about this is put your fingers on your own pulse on your wrist, all right? I hope you can feel it. If you can't, I can quickly teach you CPR. But if you can't feel it, which most of us should be able to, I want you to take a deep breath in, all right? And notice what happens to your pulse. Actually, I'm having a bit of trouble finding mines at the moment. Okay, so let's take a deep breath in, all right? And can you feel that? What happens when you breathe in? And now breathe out. And breathe in again. And breathe out. And do you notice what happens? If anybody wants to tell me. If it's just me talking to, that's fine. It's not a problem. But what you're noticing there is something that we've got that's called sinus arrhythmia. So sinus arrhythmia is the difference that happens when you breathe in versus breathing out. So when we breathe in, we take in oxygen, and that oxygen needs to be distributed through the body. So the heart picks up its heart rate. And when you breathe out, the amount of oxygen, well, of course, now your carbon dioxide levels are increasing, but your oxygen levels are decreasing. So your heart rate slows down ever so slightly. So a sinus arrhythmia is what you would see on a normal ECG. Now, it doesn't differ by much. We're just talking about milliseconds. We're not even talking about seconds. So in other words, to have an absolutely regular heartbeat, absolutely regular. In other words, it's not changing no matter what, is also abnormal. Okay. Does anybody want to venture a guess as to what our patient may have? Our patient has come in with palpitations, all right? Our patient has come in with a very, very regular heartbeat. Our patient has come in with narrow QRS complexes. In other words, they have a tachycardia, but this tachycardia is coming from above the ventricle. So in other words, whatever's stimulating the tachycardia is coming from above the ventricle. Does anybody want to take a guess as to what it may be? Or I'm not sure if everybody's shy today, that's fine as well. But I'll give you a minute to think about it. So I'll say it again. We have a tachycardia, we have a very regular tachycardia, and we have a narrow complex tachycardia. So it's absolutely narrow, right? Well, sorry, it's absolutely regular. And because it's narrow, we know that the tachycardia is coming from above the ventricle. I don't think I can give you more clues than that without actually giving you the answer. So what do you think we'd call a tachycardia that's starting from above the ventricle? Any idea? I'm sure you would have heard the term before. Okay, we have one answer here. Let's have a look and see. Very good. Supraventricular tachycardia. And dementia, that's brilliant. Okay. So you can see it's not actually that difficult. So you've got a tachycardia that's coming from above the ventricle is a supraventricular tachycardia. Okay. Now, these are the fundamentals of a supraventricular tachycardia. Number one is generally above 150 beats per minute. Number two, you can't really see P waves. So you can't talk about PR intervals and making sure the QRS, or in other words, the ventricle is always contracting after the atrium. But the QRS complexes are narrow, so we know that the ventricle is being stimulated by the atrium. But the difference is that it's absolutely regular. It doesn't change. In fact, if you put your patient on your SATS monitor or your ECG monitor, you'll find that if it's 164, it's 164. It doesn't change. And if you've been with patients, you'll notice, even if you've got a tachycardia 140, it's 143, 139, 141, 142. It keeps on changing. But with supraventricular tachycardias, it's absolutely, it's like military regularity. It just carries on like that. Now, last week we had a similar one where we also had a narrow complex tachycardia without visible P waves. We couldn't talk about anything, but the only difference was that it was absolutely irregular. So in other words, there was no connection between the QRS complexes. We could have had one there, and then one there, and then another one there, and another one there, and that. And that was atrial fibrillation. So it's important to know these 5 points about rhythm, because they will actually help you in deciding what type of tachycardias, bradycardia, or rhythm disturbances your patient may have. Now, this is not the only slide. Let's move on to the next one so that we can have a look and see. So, okay, you've decided, let me just hide this, sorry. Panel controls. Okay, so you've decided that your patient has a supraventricular tachycardia. Now, normally what we will, well, just to make it quite simple, we normally start with vagal maneuvers to be able to try and decrease your tachycardia. That's the first thing that we do. The reason being, vagal maneuvers, the Valsalva maneuver, actually helps your body to slow itself down without anything else. Now, tell me, have you guys ever had a chance to do the Valsalva maneuver on a patient? Uh, have you ever done it before, where you get a patient basically to breathe forcefully against a closed nose and mouth for about 10 to 15 seconds? Okay. Not yet. Okay. So it's quite an interesting thing when you do it, and it's quite and SVT is one of the times when you will do it. There are other conditions as well, but this is basically when you will get to do it. All right. So this is just a general Valsalva maneuver. So what the patient does is they breathe out. Let me just hide this again so that you can read it. Okay. So they fully exhale, but not forcefully. they pinch their nose tightly and close their mouth tightly, and they try to inhale, or in some instances exhale, whichever it may be. So they can inhale first and try and exhale, or try and exhale and then inhale. And then, voila is making it sound a bit simpler than what it is. We'll talk about how it works just now, right? And then you get what they call the modified Valsalva maneuver. And then that's where the patient does the similar thing, but they are sort of lying down. And then you basically get them to breathe out for about 15 seconds to 20 seconds. And once you've done that, you basically lift their feet up and then return them to this position again. Now, there's another one that's called the revert maneuver. I didn't want to get into that, but in that one there, your patient, sorry, let me just, sorry about that. And dementia, it doesn't always help, that's for sure. It's not an end all and be all, and we're going to get into that just now as well. So one of the other ways that you can do it, and like I say, it's called the revert maneuver, is actually where your patient starts like this. So they're lying down, but their legs are straight up. And then you basically make them move against or breathe against something for about 15 to 20 seconds. And at the end of it, they actually then sit up. So you then have them in that position. So you assist them by pulling their legs down and lifting their torso up. Now, how the Valsalva maneuver works is actually quite interesting. So what the Valsalva maneuver does is that when the patient is doing this, so whether it be forcefully exhaling or forcefully inhaling, is that they are causing a large amount of blood to actually rush through into the carotids. All right. So what happens is that the carotids are then being told, and you would have heard of carotid massage and things like that. So what happens is that the baroreceptors get overstimulated. They get told, oh my word, there is so much going on over here. What is happening? Why is our blood pressure so high? What is going on? So the baroreceptors themselves in the carotids then cause you actually initially to have a bit of a tachycardia, and actually to push your blood pressure a little bit up to try and counteract this. And the reason for that has to do with trying to get blood into the right ventricle to try and, change how the left ventricle is behaving and things like that. And then once you let go of that, all of that blood suddenly disappears. All right. So once your patient has now breathed out or breathed in and then let go, everything kind of slips out from that carotid artery. Everything's gone. So once they've done that, the baroreceptor then gets the completely opposite signal, which is now, oh my God, we have absolutely no blood. And, I hope I'm remembering the right way around. I may be just remembering the wrong way around. No. Initially, it's completely emptied out. Sorry. So that the baroreceptor increases BP and then increases the heart rate. And then as soon as you let go, then the baroreceptor is completely deprived. Yes, that's correct. It's completely deprived of blood. So the baroreceptor then says, okay, listen, I need to increase my blood pressure, but I need to slow down my heart rate at the same time. And that's basically how it works. I hope I remember that correctly and didn't confuse you guys more. Maybe I need to go and check it out myself. But that's basically how it works. Listen, if I got it wrong, you're all welcome to ask me for a chocolate. I will send it to you. But I remember it's a long time since I've done this. So since I did physiology, I might just have remembered it incorrectly. Okay. Now, one of the other vagal maneuvers that they teach is carotid sinus massage. Okay, so carotid sinus massage also does a similar thing in that it overstimulates the carotid baroreceptors, and that increases vagal tone, and that affects the SA node and the AV node, and that causes a decrease in heart rate and things like that. Now, the problem with this is that we don't know what's going on in this carotid. So there may be, for example, thrombi that are sitting over here. There may be plaques, atherosclerotic plaques. There's quite a few things that are going on here. And the older your patient is, the higher the chance that something is there. Now, there's nothing wrong with carotid massage. The only thing is that you first need to listen to the entire carotid. to make sure that there's absolutely no bruise, no evidence of any sort of a blockage or anything like that. And it's quite easy to do. Basically, if you're going to rub on the right-hand side, the patient turns the head to the left, and then you apply pressure to the carotid, the mid-carotid, and you massage there. You need quite a hard stimulation. So you rub it quite hard for about 10 to 15 seconds, and that it does sometimes work. But I must be honest, majority of the time, I've never really seen carotid sinus massage work. Now, that may be because everybody who did it in front of me and myself are just not very good at it, or it's just not that successful. So that's why we use the other vagal maneuvers, such as the Valsalva maneuver. In children, it's advised that you put something cold on their head if they are in an SVT. That seems to work quite well, and I've seen it go down. But unfortunately, vagal maneuvers and all of these types of things are actually not that successful in a lot of patients. All right. So let's go through what we actually can do. Okay. So the question is whether the patient is in shock. Now, the best way for you to know whether the patient is in shock is to look at their blood pressures. So what we are saying over here, now this is the ACLS algorithm for how you manage an SVT, all right? So does the patient have shock? Yes. You can start with vagal maneuvers immediately. You can establish quick vascular access. Yes, very good. However, what happens if you've got a very large patient and things like that? So let's take the situation of a patient who's presenting to us with an SVT, supraventricular tachycardia, was quite thin, has good veins. All right, let's take that as one. So the shock is present, their BPs are quite low. We've tried our vagal maneuvers and we can get an IV line in very quickly. So what we're going to do is that we're going to give the patient adenosine. Now they're saying 100 micrograms per kilogram. The general rule is 6 milligrams of adenosine. Now, adenosine has to be given extremely tightly controlled. Adenosine, as soon as it hits the bloodstream, it disappears completely. It's completely inactivated. So in all my years of working in the emergency department, in all of the times that I've given adenosine, I've given it exactly how it's supposed to be given, three-way taps. There's a whole way out that it needs to be given. I have never seen adenosine work. There have been multiple studies now that have shown that adenosine is probably one of the worst. However, it still appears because when it does work, it is extremely, extremely effective. However, in reality, it doesn't really work. So what most of us do now is that we skip over the adenosine and we go straight to amiodarone or any other anti-arrhythmic. But in South Africa, amiodarone is the most commonly used one. And the easiest way to give it is to give an initial bolus of 150 milligrams in 200 mils of, it's either 5% dextrose, so I think Ringer's lactate, and you give that over about 10 minutes. Okay. Now, what will happen is that the patient will start to have a reaction to that. However, because it is over 10 minutes, it's not often the best thing to give if your patient is in extreme shock, which I'll get to now, all right? But having used it now quite a few times, it works much better than adenosine. So I don't like teaching people about adenosine because it doesn't really work. It really hasn't helped many people over the years. Okay. If any of you have had experience with adenosine, please let me know. And if you go for your ACLS course, please don't just go there and tell them, oh no, adenosine doesn't work because Dr. Mohammed said it doesn't work. It is part of the exam for ACLS and for most of your cardiac exams. So please remember, adenosine is there. I'm just saying practically on the floor. I've never seen it work. And I've read about 5 or 6 papers on different ways to give it, from the correct way to the most weird way, and none of them have worked. So basically what adenosine does is it goes in and it stops the vagal nerve completely. It just shuts it down. So when the vagal nerve shuts down, there's no stimulation of the SA node. So the heart stops and then it restarts. That's how adenosine works. The way that amiodarone works, amiodarone actually lengthens the time between ventricular contraction and ventricular relaxation. To put it simply, I've got another presentation coming where I'll explain it a bit better. So that's how amiodarone works. So amiodarone tends to have a much better outcome, and it tends to work over those few minutes. Now, let's take another patient, for example. Now, oh, sorry about that. Now we've got a patient coming in very much overweight, or let's say very dehydrated or whatever it is coming into your emergency department, is in shock. You're not going to be able to get vascular access quickly. What is the other thing that you can do? And that is a synchronized cardioversion, right? I wonder if you guys can tell me on the chat, have any of you done a synchronized cardioversion at all? Or have any of you seen it? I'll just give you a second to type out. It's not a problem. Okay. Okay, all right. So, yeah, oh, okay, all right. So, you guys haven't seen it. So what I'm going to do is that at the end of this lecture, I was planning to do it on a later lecture, but I'll actually put it up now. There's a wonderful video that I found that explains it from top to bottom, how it works, how you set up the machine and things like that. It's basically defibrillation. That's it, all right? But it's defibrillation where we are trying to stop the heart when it's contracted at its hardest, all right? So in other words, at the peak of the R wave. Now, okay, now, Dr. Sangweni, you actually don't, you just need pedals to do it. So don't worry. Hopefully one day I will show it to you all in casualty. You don't actually need pads. That's one of the ways that you can do it, but you can actually do it with pedals. But basically what we do with synchronized cardioversion is that we are now, well, defibrillation, all right, to put it bluntly, defibrillation is your heart is fibrillating. It's just moving all over the place. There's no rhyme or reason to how it's contracting. So what we are doing is the equivalent of switching it on and off, like what you do with your phone, all right? So when you do a defib, when they on ER and all of these, these shows where they say clear and they go in and the patient comes back to life, it's a miracle. So that defibrillation is essentially passing current through the heart to stop it, in the hope that when it restarts, it will restart correctly. Now, synchronized cardioversion is slightly different. Synchronized cardioversion, what we are doing is that we are waiting for the peak of the R wave. So let's go back. Let's go back a little bit to our ECG. So what we are trying to do is that we are trying to hit the heart at this point when it's at its absolutely most contracted. And the reason for that has actually to do with the movement of what you call it, sodium, potassium, calcium, all of these ion channels that have been opened and closed at that particular time. So what we are doing at that point is by hitting it at that point, we're resetting those channels as well. So what happens is that when the heart restarts, because remember, we are still hitting it with electricity, so it will start, but starting it at that particular point will actually lead to a decrease in the tachycardia. Okay, now these are quite complex subjects, and I don't want to get too heavily into them, but just so that you understand the basics of it, all right? So I'm going to put up that link to that video, and I would suggest you, it's just about 4 minutes. They just show you exactly how they do a synchronized cardioversion, and it's very easy. Now, once the synchronized cardioversion is done, now don't worry about this. On an adult, you start at 100, then you go to 150, and then you go to 200. Although in my experience, 100 or 150 is normally more than enough. Once you've gotten your patient out of the tachycardia, to keep them out of a tachycardia, you then keep them on amiodarone. Now, each hospital has its own protocols when it comes to this. Our protocol is to put 150 milligrams in 200 mils of fluid and run it between 5 to 10 mils per hour. Amiodarone does have its own side effects, so you can't just give it willy-nilly, all right? So in this case, this is just the answer to what we had seen. So we had a paroxysmal supraventricular tachycardia, which is another word for a supraventricular tachycardia. at a rate of 190. The differential diagnosis of narrow QRS complex tachycardias includes sinus tachycardia. Sinus tachycardia generally, like I told you, is not over 150. It's often, as I say, it's normally just referred to as SVT. You can get atrial flutters, but please don't worry about that. We will get to that. Let's just get to the other things that it can be. So the ECG lacks obvious P waves or flutter waves, so the diagnosis of SVT is made. ST segment depression is noted in the inferior lateral leads. It's a common finding of SVT without clinical relevance, as the ST segment depression resolves after conversion. So the question you may want to ask yourself, this is just a joke just to finish off, is why do we need to control this patient's heart rate? And the reason for that is, well, how many of you go to the gym? Now, all of you have seen me know that I don't go to the gym. Otherwise, I wouldn't weigh as much as I do. But there was a stage where I did go to the gym. I was actually much thinner than what I am now. And, if you've been to the gym, to get your heart rate up to 150, 155, 160 is not easy. And it takes a lot of physical effort to actually get it up to that point. So for a person to have this heart rate of 160, 170, 180, 190 is not sustainable. So that is why we just want that. That's why we need to control the rate. Now, for those of you who watched last week, remember we said with atrial fibrillation, the first thing we want to do is make sure that there's no clots and then control the rate. And that was a whole discussion on its own. But at the end of the day, we still want to control the rate, okay? So the reason being, we don't want this heart to suddenly stop and go into arrest because it cannot keep up with what it's supposed to do. Secondly, the heart has a higher chance of going into an ischemic situation. Yes, we do have to give the patient sedation before we cardiovert as well. My advice to you would be, if you haven't done a cardioversion before, don't suddenly take it on yourself. Ask somebody who has done one before to show you. So it's a case of see one, do one, teach one. It's one of those. But yes, you normally do have to sedate them, but it also depends on their level of consciousness. I normally give them Domicum and a bit of morphine as well to ease them up, and then it helps to cardiovert after that, because it's a very unpleasant feeling to have that amount of electricity passing through your heart as well. Okay, so according to Zoom, we've just got a few minutes left. There was quite a bit to cover today, so that's why I went a bit fast. But if there are any questions, now is the time to ask them. Because SVTs are something that you are going to see quite often in your career. So it doesn't matter where you work. You can work in surgery, anesthesia, internal medicine, emergency medicine, outpatients. You're going to get patients with palpitations, and at least 10 to 20% of them are going to end up being an SVT. So the first thing is that you need to be able to identify it. The second thing is at least be able to try the vagal maneuvers. And then the third thing is, if they are really, really bad, know how to do a synchronized cardioversion. You must remember, at the end of the day, even a radiologist needs to know how to do a defib and cardioversion, because we're all expected to know that as a baseline of our medical knowledge. Okay, now, like I say, I'll put the video up on the link to the video on the group. It's a separate video from YouTube. I can't include it in this. So I just got a separate one, and you'll see it there. And it's so simple. It's so easy, really. It's one of the simplest things you can ever do. You do it with paddles, or you can do it with pads. You're not talking about pacing a patient, nothing like that. And, actually with synchronized cardioversion, you're more or less guaranteed to get the person out of a tachycardia. The problem with cardioversion is that you are passing electricity through the heart, so you are causing direct damage to the heart. So that's why it's often left as the last resort. So I'm not sure if anybody has any questions or anything like that, or yeah. You can just ask on the chat if you need to. It's not a problem. Okay. Well, I hope everybody enjoyed it. I hope everybody understands how you diagnose an SVT now. and it really is a common diagnosis. So please, if you didn't catch everything, please try and go back and watch it again. Okay, no, that's fine. Thank you very much. I appreciate that. That you guys understood that. And hopefully on Wednesday, we'll go through another type of ECG so that you guys can, because it's not only rhythm disturbances and tachys and things like that. You need to know about ischemia and all of that. So we'll try and cover that as well on Wednesday. And thank you to those of you who joined. I really do appreciate it. It really makes my day to know that people are interested in these topics as well. Okay, and I'll put the video up on the YouTube channel, and I'll also make sure that I put out, thanks to all of you as well, and I'll make sure that I put up the link to the synchronized cardioversion video so you guys can watch that as well if you've never seen it before. Okay, but if that's it and everybody's happy, then we'll call it a night. And yeah, no, thanks as well. We really thank everybody who's been here today and enjoyed it as well. And hopefully we'll have a chance to have another one soon. Okay. Okay. And yeah, let's call it a day. And yeah, hopefully we'll have another one soon. All right, keep well, everyone. And like I say again, thank you so much. Keep well. Bye-bye.